and they deserve this round of applause. So honorable chairpersons and all esteemed colleagues on the floor, I have been allotted an offbeat topic. I hope I am able to do justice to this particular topic allotted by Dr. Vipul and Dhruvi to me. So I'm going to speak about an endocrine issue, and that happens to be acromegaly, a case-based perspective. My flow will cover these learning objectives. I'll try to understand the clinical presentation and history of acromegaly and discuss the diagnostic strategies, outline modern management approaches, and review a representative clinical case. Basically, acromegaly is a rare disorder caused by excessive growth hormone. All of us are aware of that, growth hormone secretion. It most often happens due to growth hormone secreting pituitary adenoma. That's one of the commonest causes. And onset is typically insidious, very slowly progressive disease, and multi-system involvement is the rule. High morbidity if we don't treat this particular category of rare disease. So again, there is a technical definition on this slide. Acromegaly is a chronic progressive hormone hypersecretion syndrome caused by an excess of growth hormone after the growth plates have closed, that is after puberty. So if prior to puberty, it would be called gigantism. And the hypersecretion of growth hormone is the result of oversecretion of growth hormone releasing hormone that comes from the hypothalamus, or oversecretion of hormone itself from a pituitary adenoma. So these are the typical clinical features. This is just recapitulating our physiology days and early years of medical education. So if you see at the cartoon from the top, headache, enlargement of lips, nose and tongue, even cardiomyopathy may be picked up. Other cardiovascular diseases are also 2 to 3 times as common compared to normal individuals. And then you have hypertension, enlargement of liver, which can be palpated or can be proved on a sonogram, enlargement of hands, arthropathy, and carpal tunnel syndrome. Why that happens? Because excess body fluid and tissue thickening can lead to thickened tongue and throat and swelling in the throat area, which can account for the obstructive sleep apnea. And in the hands, it can lead to carpal tunnel syndrome. Then you have few more on the right side. You have skull growth with prominent supraorbital ridges and large frontal sinuses. Prognathism, which is growth of lower jaw, not necessarily lower jaw all the time. It can be the upper jaw also. And then I have another cartoon coming up for that, explaining that to all of us. And then there can be increased sweating, thickened skin, and 25% of these guys will have IGT, and a good 10% will develop concurrent diabetes. And then colonic polyps and cancers are very common. Myopathy, there may be a bulky muscle mass, but the muscles don't work. Dr. Akash Singh just referred to sarcopenia. This is sarcopenia in a different setting. So you have myopathy, and then lastly you can have enlargement of the feet, increase heel pad thickness. So here is my case vignette. A patient introduction briefly captured here. Mr. Ramesh, 52-year-old male, a known hypertensive. His height is 171, weight 76, that gives him a BMI of 26. He has been complaining of enlarged hands and feet, facial coarsening, joint pain. उसकी अर्धांगिनी बार बार बोलती है, क्या हो गया, आप क्यों ऐसे जानवर जैसे हो गए, राक्षस जैसे हो गए हो. So fellow is highly distressed. He comes to us, and then we proceed ahead. Apart from these complaints, he also has observed increased shoe and ring size. He snores a lot. That is what his wife has been complaining, and remains very fatigued during the day. And he has the evident frontal bossing, prognathism, widened interdental spaces that can give rise to biting during eating. And he has enlarged tongue, sweaty palms, and coarse voice. So I have tried to, I don't know whether this pointer is working. This is maxillary prognathism. The maxillary bone protrudes beyond its recommended anatomical normal limits. And then there is a jaw without any prognathism in the center. And then we have mandibular prognathism to the right, and which is what our patient has been suffering from. His other associated symptoms and comorbidities include headache and visual disturbances. He has classical carpal tunnel syndrome, arthropathy and backache, for which he has been taking many times painkillers, SOS, and he has been found to be having pre-diabetes apart from his established hypertension history. So what is the pathophysiology? This is captured in the briefest possible way. Basically, growth hormone hypersecretion triggers increased production of insulin-like growth factor 1 from liver, which mediates all the growth hormone effects. So basically, IGF-1 levels are the ones that we pursue while assessing acromegaly patients. It's responsible for the tissue overgrowth, and the commonest culprit is pituitary adenoma, and these tumors can compress optic chiasm, leading to bitemporal hemianopia. So what is the diagnostic approach? The gold standard is to look at some hormonal levels. IGF-1 levels remain persistently elevated, and then we can subject such patients to oral glucose tolerance tests while studying growth hormone levels simultaneously. That is known as OGTT-GH growth hormone suppression test, and the result, usually confirmatory result, is failure to suppress that growth hormone secretion. And then random growth hormone levels, please mark this, they are not very much reliable, they are less specific. So what is pursued is IGF-1 level. So at the bottom, I have tried to humbly explain. In an OGTT for suspected acromegaly, the key indicator of the condition is growth hormone suppression failure, meaning the pituitary gland doesn't suppress its growth hormone secretion despite elevated blood glucose levels, as we load the patient with glucose and challenge the patient with oral glucose. And normally what should be happening? After consuming glucose, the body releases insulin, which in turn signals the pituitary gland to reduce growth hormone production. In acromegaly, this particular phenomenon, this suppression is impaired. And this is the biochemical profile, the first slide capturing biochemical profile. This is standard, delayed 5 to 6 sample OGTT. So we start at 0 minutes, go through 30 minutes, 60 minutes, 90, 120 and 180 minutes, and look at the glucose levels. He has been a pre-diabetic, kindly note that, and look at the growth hormone levels. Then now during OGTT challenge, the growth hormone secretion should be subdued to less than 0.4 nanogram per ml. That is why GH reference is same for OGTT purpose only. Otherwise, in normal individuals, the growth hormone should be less than 5 nanogram, where there is no suspicion of acromegaly, and the fellow is hale and hearty. And these are IGF levels which are very significantly elevated, 610. Prolactin is mildly elevated. TSH, FS, LHH, LH are all within normal range. Testosterone is slightly below the desired range. That could be also partly due to the increasing age of that. He is around 52. 8 AM cortisol, again normal. HbA1c is 6.1%, typically in the pre-diabetic range, and creatinine was normal. So we opted for a pituitary MRI with magnified pituitary slices and gadolinium contrast, and a well-circumcised figure of head-shaped cellular mass was identified, measuring 2.6 by 2 by 1.8 centimeter with supracellular extension. So the arrows, and they are self-explanatory. This is a brilliant MRI from one of our city's leading radiology clinic, and they assisted in the final diagnosis of this particular patient. So the restriction of adenoma growth by diaphragma cellae results in snowman. That is the technical term used in US, because there lot of snow happens there. So ek godo dado snow no ek ni upar bijo muko, it becomes like a figure of 8. So we desi people prefer figure of 8 terminology. So although the mass did not extend laterally into the cavernous sinus, that is another major common diversion, but that didn't happen in this person's case. But the cellular mass extended upward into supracellular cistern through a hole in the dural, the diaphragma celli, to compress the optic chiasm. So we did the perimetry test and challenged his visual field testing. What we found that visual field on confrontation suggested lateral field deficits, which is described as bilateral lateral hemianopsia, and that is also explained in the at the bottom. It refers to a visual field defect affecting the outer or temporal or lateral half of vision in both eyes. Patients commonly report difficulty in seeing objects on the side of it's a tunnel vision which is intact. On the sides there is an issue. And they can bump into obstacles, they can really get injured, having spatial awareness problem and experiencing double blurred or distorted vision. Then we did polysomnography, 2D echo, ECG and colonoscopy for this patient. So apnea hypopnea index on sleep study came to 27 events per hour. Normal is less than 5 events per hour. ECG and 2D echo respectively showed borderline LVH with a 54% preserved ejection fraction. And colonoscopy told us that there were few diminutive polyps. Diminutive polyps are typically less than 5 millimeter in size, and they are mostly benign in the sigmoid colon. So how did I come to the diagnosis of this patient? I identified the clinical phenotype. I could document elevated IGF-1, and at the same time I could document lack of growth hormone suppression on OGTT, and the clinching diagnosis final stamping was done with the help of MRI evidence of pituitary adenoma, macroadenoma. So what should be my treatment goals for this patient? I would aim to normalize the growth hormone and IGF-1 levels, remove or reduce the tumor mass, at the same time make sure I preserve the pituitary function and relieve symptoms and comorbidities. So these are the aims of my treatment protocol for this patient. Now primary treatment is surgery. It's a treatment of choice, where transsphenoidal surgery remains the first line for resectable tumors. So where there is not much infiltration into the surroundings, where there is a clear-cut adenoma, then the surgeons help us, neurosurgeons, they help us in through the transsphenoidal approach, remove that. And that has high success in microadenomas and non-invasive macroadenomas. Now, suppose the patient flatly refuses, or the patient for any XY reason is unfit for surgery, then we have some medical therapy options like somatostatin analogs, octreotide and lanreotide. Then we have growth hormone receptor antagonist, pegvisomant, which goes by, if you can read that name, Somavert. It's from Pfizer, and it's a sub-Q injection. It's a lyophilized powder which the solution has to be prepared. Then we have dopamine agonist at the bottom, cabergoline we have been using for years. And then lastly, when are these options to be exercised? They are used in non-surgical candidates or residual disease. So once surgery has happened, if it is found on a follow-up MRI or on follow-up biochemistry that there is a recurrence or residual tissue, then these medicines come very handy. Radiotherapy is another option. It is indicated for inoperable, resistant or residual tumors. Stereotactic radiosurgery using a gamma knife is one of the procedures. However, there can be a delayed efficiency of this radiotherapy protocol, which can lead to panhypopituitarism. So we have to be careful about this particular. I am approaching the end of my presentation, and then looking at comorbidity management. For example, my patient had hypertension and borderline LVH. I should be very careful about that and medically try to assess these findings. Then he remains a pre-diabetic person. Probably it is insulin resistance due to growth hormone excess, which is causing. He had typical IGT, figures in his extended oral GTT test. He has sleep apnea. I would like to discuss and offer him CPAP. And arthropathy should be jointly treated with the help of a rheumatologist colleague. Colon polyps we have already screened him for, and we will periodically do a follow-up colonoscopy. Then how do we generally follow up such patients? We would be doing IGF-1 and growth hormone levels every 3 to 6 months post-operative, predominantly IGF-1. I wouldn't be keen on growth hormone levels. Repeat MRI annually for residual or recurrent tumor. Monitor pituitary function and screen for any newer developing comorbidities. So what happened to my case? Mr. Ramesh underwent successful transsphenoidal surgery. Post-op IGF-1 totally normalized. I am going to share some good redeeming figures with you. Snoring improved, his antihypertensive could be tapered, and he continues annual follow-up with us. So after surgery, this is what happened. Growth hormone came down to a low of 0.38 nanogram per ml. Here the normal range for an individual who has already done with surgically the macroadenoma has been removed, then the normal range is less than 5 nanogram per ml. And in the OGTT challenge, it is less than 0.4 nanogram per ml. So there shouldn't be any confusion about the two differing figures. Then after 1 month, 3 months and 1 year, you can see gradually decreasing levels of IGF-1. That means the surgeon has done a very good job and our patient is likely to improve significantly. So the key takeaways from my humble presentation, honorable chairpersons and friends, we need to think of acromegaly in patients with coarse features. एकदम डरावना चेहरा जिसे बोलना नहीं चाहिए. All patients are, meaning no offense, but जैसे कई बार एकदम देख के अपने चौंक जाते हैं, अरे ये भाई इसको क्या है? And we see such figures on the screen and so many movies. So whenever we have to think of acromegaly in patients with coarse features or acral changes. Acral means hands, feet, nose and ears. And IGF-1 is the key diagnostic hormone. Surgery remains the first line, but multimodal therapy may be required. As we saw in this patient, I would have offered him CPAP, I would have addressed his hypertension differently, his pre-diabetes differently, and that means it's not just one therapy that you offer, but maybe a multimodal approach. And these are the references on which I have based my humble presentation. They are all contemporary. Thank you very much for your patient hearing.